Now, it is my great pleasure to present the next speaker. The next speaker is Dr. Paul Roux from South Africa. He is specialist, reproductive medicine specialist in South Africa, and he is the president of the African Federation of Fertility Society. Paul is going to address us on what is the best management of abortion for future fertility. Paul, the floor is yours. Thank you.
Thank you very much. Yeah. Thank you very much for inviting me to speak, and it's a great pleasure to be here. I'm going to talk today about the best management of miscarriage for future fertility. And I think, as I said in the beginning, this is an interesting session because management of miscarriage is something we all just take for granted. I mean, we learn this as junior doctors. I think I did about 1,000 evacs when I was a junior intern or senior house officer without much thinking. So it's sometimes a good thing to think about what we're doing and whether it's causing problems in the future. I work at Cape Fertility, which is a private IVF center in Cape Town, and my colleagues are in the picture there. So when did it all start? When did people start to realize there might be an issue? So intrauterine adhesions were first called the Fritsch-Asherman syndrome. Fritsch was a German gynecologist in 1894 who first described intrauterine adhesions after medical intervention after a miscarriage. So it's a long time ago. And then Asherman, whose name is familiar to all of us, was an Israeli gynecologist who made a publication in 1950 that made us more aware of intrauterine adhesions. So the sequence was Fritsch had a series of 1, so he had his 1 case. Bass published 20 in 1927, Stammer in 1946 at 24 cases, and then Asherman had his series of 65 in 1950. So Joseph Asherman is an interesting man. He was born in 1889 and died in 1968. He was born in Czechoslovakia and went to Prague University, and then he immigrated to Israel and became the president of the Israeli Society for Obstetrics and Gynae, and he died in 1968 in Tel Aviv. He first made a publication of 29 cases in the interesting name of the journal, Journal of Obstetrics and Gynecology of the British Empire. There we go. So, and he talked about something called amenorrhea traumatica, which he realized was injury to the uterus by deep curettage following miscarriage. And this caused obliteration of the endometrial cavity with amenorrhea ranging from 3 to 12 months. And he diagnosed these cases on HSG. That's how he worked out there was intrauterine adhesions. And what he did is he just put a uterine sound through the internal os and dilated the cervix a bit, and he actually managed to restore menstruation in about 27 of the 29 cases, and 10 of them got a pregnancy. So he did his little early intervention for Asherman syndrome. And then in 1950, he published a bigger series of 65 cases where he actually did a hysterotomy and put his finger in the uterus and broke down the adhesions like that. But even in 1950, he said, hysteroscopy, because hysteroscopy had been used then, they were just using gas hysteroscopy at that stage. So he said hysteroscopy, which has often been mentioned in literature and often is discarded, may perhaps be of use for this purpose. If it were possible to see the adhesion and to loosen them instrumentally using the eye as a guide, the ideal method would have been found. So he was quite forward thinking in his way. So what is Asherman syndrome? So it's based on diagnosis of 2 criteria, intrauterine adhesions and amenorrhea. And normally they were talking about the post-pregnancy complication, but we know there are obviously other causes of adhesions. For example, when a myomectomy is done or there's infection like TB of the uterus. And these days the gold standard is hysteroscopy. So what causes it? Well, you're basically damaging the basal layer of the endometrium, causing the 2 opposite walls to adhere together. And, there are many reasons for this: intrauterine trauma, the technique, infection, inflammation, and retention of trophoblastic tissue as well. Is there classification for Asherman syndrome? Well, it's not universally used. Firstly, there were lots of different inclusion criteria. There was a classification of Charles Mark, there was a ASRM one, ESG one, there were lots of different ones. And if you look at all the different classifications, they're extremely confusing, to be honest. And that's why most people don't end up using them, because each society had a slightly different way of doing it. So the simplified classification is basically mild, less than a third of the cavity, moderate, 1 to 2/3, and severe, more than 2/3. And then complete Asherman's syndrome or complete uterine adhesions, no cavity. So when did they first start realizing that if you did a miscarriage and you curettage afterwards would be a problem? Well, you can see here in the 80s already they realized if you had a miscarriage, you had 30% chance of getting adhesions if you did a curettage. That was a long time ago in the 80s, and I don't think that message came across very well. And if you had recurrent miscarriage, up to 48% of patients had adhesions. That was published in 1994 already. So the diagnosis is based on changes in the menstrual period after DNC. Inability to sound the uterus was the historical way they diagnosed it. But obviously now we can look on ultrasound, we can see densities, irregular lining, thin endometrium or hematometria. And you can use saline sonography, HSG, MRI, and obviously hysteroscopy. So if you look at first trimester miscarriage, about 15 to 20% of all pregnancies end in miscarriage. And there are different ways of managing it. You can manage it expectantly, just wait and see. You can do medical treatment with mifepristone and misoprostol, or you can do surgical treatment, which is basically like an EVAC or DNC. So first, one of the good studies was done by Angelo Hooker. This was published in 2004, where he started to look at properly intrauterine adhesions after miscarriage. And what they did is they found, to summarize, they found about 19.2% of all the women who had an EVAC in their series had miscarriages ranging from mild to severe. But interestingly, there were none in the spontaneous or the medical group in their study. And they obviously concluded that recurrent curettage procedures were also the worst because they had 50% intrauterine adhesions. So this was published in 2014, and this started making an impact more in the medical world. And we must remember, first, do no harm. So if we go and curette someone's uterus, we may be actually putting them in a difficult position in the future. So we must think of alternatives to surgical curettage. Expectant management, about 50% of the patients will miscarry quite fine within 2 weeks without any significant increase in morbidity. And a medical evacuation using mifepristone and misoprostol is basically equally effective as a surgical one. Both of them have very high pregnancy rate and they tolerate it extremely well. So the next question is, does intrauterine adhesions matter after a DNC? So if you get adhesions, so what? So 20% do, but does it make a difference? So there was a PAPA study which looked at this in 2021, and they looked at 152 women with first trimester miscarriage. So the women had a miscarriage, and they did a hysteroscopy 2 months after the EVAC to see what was going on after the EVAC. And they actually fixed it even if they could see something wrong. And what they found was, if you look at ongoing pregnancies, if there were adhesions found at that hysteroscopy, the ongoing pregnancy rate was 58%. This is with fixing the adhesions as well. Whereas if they had no adhesions, the patients had 90% chance of ongoing pregnancy if they wish to conceive. So if you find intrauterine adhesions, even if you fix them, you've got a lower chance of the patient having a baby in the future. So we must understand that intrauterine adhesions have an impact on reproductive performance, even after hysteroscopic adhesiolysis. And primary prevention is essential, so avoid curettage basically. And we must think of the other techniques. And then the next question is, okay, so if we're doing an EVAC, if a doctor is doing a DNC or EVAC, can we prevent adhesions as well? And what about putting in hyaluronic acid gel? So this study looked at inserting gel after a DNC procedure. And they looked at first trimester patients and they randomized them to getting gel or not. So what they found was basically that it did make a difference. The patients who had intrauterine gel put in had a much higher chance of having ongoing pregnancies compared to the patients who didn't, as well as live births. And this was also done in a Dutch study, a very good study in 2019. They also had 300 patients, and they also randomized them to get gel or not after an EVAC. And again, they found the same thing. If you put the intervention, put the gel in, the adhesion rate went down to 9%. If you didn't put gel in, it was 24%, which is consistent with previous studies. The next question that people often ask is, yeah, but if you do this medical treatment, sometimes there's still tissue stuck in the uterus. So that's bad. The patient's going to get infection, or maybe there's going to be problems in their uterus. So this study looked at incomplete medical treatment. So they looked at incomplete evacuation after medical treatment. They did an ultrasound after 6 weeks. And what they did is, and then they managed the patients either expectantly, they did nothing, they just left the tissue in the uterus, or they did surgical curettage. And what they found was that both groups actually did well, but there was actually less complications in the expectant group. So you don't have to rush and go and do an evac on a patient, even if you can see some tissue in left after a medical evacuation. So the conclusion of that study was in incomplete evacuation of the uterus using misoprostol, expectant management is an effective and safe option, and we should be still restrained in trying to curettage them further. Okay, what about trying to do things more gently? So you've got some tissue stuck in there. What about hysteroscopic removal rather than doing another DNC? So this is a study that was looking at that using hysteroscopic removal, and I'm not going to go through it in detail because of time, but basically to say hysteroscopic removal of retained products seemed to have no detrimental effect on reproductive outcomes. So it didn't cause the same degree of adhesions as another evac or DNC. And this is another study on the same thing, and they looked at hysteroscopic morcellation. That's, for example, using a True Clear or a Bugatti shaver, one of these instruments, and compared it to loop resection. And they found the hysteroscopic morcellation was a bit faster than the loop resection, but both had good rates of removal and low rates of causing adhesions. So to summarize my entire talk, always consider alternatives to DNC. Always consider an expectant management or medical if you want to preserve the patient's fertility. You must remember that if you do a DNC, it causes adhesions in up to 20% of cases. If you're going to do a DNC for some reason, then please consider inserting hyaluronic gel as well to prevent this problem. Adhesions are important for reproductive outcome now, and there's lots of studies showing that there's a decreased fertility rate if you've got adhesions. A second DNC is a disaster and causes up to 50% of adhesions, so you must be very cautious before you do that. And if you really feel like you have to go back into the uterus, then rather do it hysteroscopically and preferably perhaps use one of the new morcellator devices. Thank you so much.